Starting the topic of principles of EOLC again. So earlier on, there was some technical glitch for which I had to log off in between, and I'm going to redo the slides. Okay. I'll be starting with principles of EOLC. So before understanding what is end of life care, we need to understand what is palliative care. As WHO defines it, palliative care is an approach that improves the quality of life of patients, both adults and children, and their families who are facing problems associated with life-threatening illnesses. It prevents and relieves suffering through early identification, corrected assessment and treatment of pain, and recognition and alleviation of problems, which is either physical, psychosocial, or spiritual. Is palliation and hospice the same? No. Mostly, hospice is something that we do at the V end of life, okay? That is towards the very end. And usually, the life expectancy should be less than 6 months. Usually, in palliative care, there is no time limit which is there. But on the treatment goal aspect, both are looking at comfort care and there is no focus on curative treatment, okay? Sometimes in palliation, you can think about both palliative reduction surgeries, okay, palliative chemotherapy, so on and so forth. But majorly, it is looking at comfort care as well, okay. Palliative care can be given both in hospitals, clinics, and home. Hospice, also similar to palliative care, can be given in this above said locations, okay. Services goals, most of them look towards the same. Only palliative care requires some amount of specialist treatment, okay. By and large, hospice would be mostly nursing and allied sciences. Okay, probably some amount of counselors. Okay, psychologists, etc. They are who form the treatment team in a hospice care. Okay, so this is the major difference between palliative care and hospice. In any disease per se, whenever we're talking about palliative care, whenever someone has been screened for a terminal illness like cancer, and the diagnosis of cancer has been made, or any sort of a malignancy with poor outcomes, always there will be some amount of curative treatment which is started in the initial stages. At the same time, there is also search for medical futility. Okay, as time progresses, if the curative care is not working out, the patient can be switched over to palliative care. And when we are doing so, we have to inform both the family and the patient that all possible curative treatments have been given and we are entering towards a phase of medical futility. And in the end, usually we need to understand that patient will succumb to the disease more so faster than ever. And when death comes, it should be in a dignified, pain-free way and not as a sudden surprise. Most of the times after death, the family still will be dealing with the repercussions of the terminal illness. So bereavement care is also necessary. So whenever we are dealing with a terminally ill patient, especially in settings with critically ill patients who come to us in the V end of the disease, we need to be aware of initiation of good practice statements like end of life care. Okay. So what is end of life care? Similar to the definition of palliative care, WHO has also given a definition for end of life care. It is care that helps all those with advanced, progressive, incurable illness to live as well as possible until they die. Okay. Similar points have been raised by two other societies like the National Health Service and the NICE. Okay. So they all focus at advanced, progressive, incurable illness patients wherein they can live as well as they were during the period of death. Okay. So what are the key principles of end of life care? They are person-centered care or patient-centered care, pain and symptom management, communication, holistic approach, quality of life maintenance, family support, multidisciplinary team approach towards end of life, ethical practice, and access to care. Okay, so coming to each part individually, patient-centered care is one of the important things in end of life care. We need to respect the patient's autonomy. All the options available for treating that illness has to be given. Whenever there is futility of care, patient has to be appraised about those issues, okay, so they can take a right decision. If at all the patient has a medical advanced medical directive, that has to be checked and that has to be upheld. Okay. Along with medical management, all the other associated things, that is personal choices, cultural and religious values, have to be upheld. Pain and symptom management is the only thing which can be continued until the time of death. So that has to be always sought after and treated. Okay. So patient usually will be in a state of depression that has to be sorted along with pain, because both go hand in hand. Anticipation of other associated symptoms like pulling of secretions, okay, and wound care, etc., nutrition, all of this have to go hand in hand when we are treating a patient in terminal illness. Communication is another important concept of end of life care, wherein clear, honest discussions about the prognosis and outcomes has to be given to the family and the patient. Regular updates as and when things changes have to be given, and you should be sensitizing the patient, and you should be aware of their cultural beliefs as well when we are communicating. Okay, so always a decision making should be an informed one. Okay, and a decision should be made when all the possible choices are given to the individual and the family. Holistic approach is, as I told you, it is not just medicine alone. We have to look at the emotional aspects, spiritual aspects, etc. Both the patient and the family would be thinking about all possible ways to get out of that illness. So if they at all they have some belief, that has to be upheld. Quality of life is very important. Okay, we should not give up on these patients. We should focus on their nutrition, mobilization, okay, and think about rehabilitating these patients as well as much as possible until they succumb to the terminal illness. So quality of life can be improved with family support. So whenever we are talking about family support, it should involve a good care plan. Okay, it should be told about what are the choices that the family have, what do we do about symptom management, okay, and about rehabilitative activities. In the end, when the patient passes away, even bereavement support should be given to the family, okay, so that they can recuperate the loss of the loved one. So coming to multidisciplinary team approach, this usually starts at the time of initiation of palliation. So curative treatments which are done to reduce the disease burden and medical management should start off, and at the same time when there is approach towards futility, start involving the palliative team at that particular time, so that there is a bridging between the past treating physician to the next particular team. So when this bridge is happening, whenever we come to an understanding of delivery of end of life care, there will be a consensus between all the treating parties involved, wherein we can sit down and discuss it with both the patient and the family, so that we have a clear communication and we can reach an informed consent. Okay, so comprehensive care planning is what is the overall outcome in a multidisciplinary team approach. Coming to ethical practice is again using all the four pillars of ethics of EOLC. Okay, so that is the autonomy, non-maleficence, beneficence, and social justice with dignity. Okay, so access to care, so they should have all the facilities available for a non-terminal ill patient also. Okay, whenever they want to access OPD patient, labs, etc., if at all the patient is willing to get any of those services, it should be available. And then the patient and the family should be made aware about other supportive equipments that they would require, and to maintain all of that, if that all a home-based end of life care is being practiced. Okay, so transitioning from a healthcare setting to a home setting, we need to tell them what are the requirements, how to do that, look for red flags, and whenever they might require emergency care, what is the point of care, a number or a contact that they need. All of this should be provided to them. So settings, I told you, it can be home, hospital, hospice, or care home, other nursing care home. All of this is something that is based on infrastructure. You should tell them what is necessary. Okay, so at home is where you need to tell the family as to what are the basic requirements which would be there for the patient at the bedside, so that he gets optimal medical treatment even at home. Okay, so this is just continuity of care which can be done in any of these places. If the patient is extremely sick and the family does not want to continue care at home, they can be moved to a hospital where separate units should be available for end of life implementation, so that if at all things are going bad and the patient passes away, bereavement can be done without any breach in the personal space of the family. The family can always be present at the time of death of the patient, so that that particular breach or the emotional aspect is always addressed. Okay, so hospice and care homes will have separate infrastructure which is required, which is very bare minimum, only focusing at pain relief, okay, and counseling, etc. Okay, so these things are the ones which are usually focused in hospice and care homes. So in end of life care policy, which was given by IACCN, there are certain infrastructural requirements for implementation of good end of life care practices. Firstly, there should be a written policy in the hospital, and everyone should be aware of this policy. Okay, so awareness and implementation should come as an administrative issue, and it has to be done by the hospital's administration. Then space and staffing is the next important infrastructural requirement. Dedicated space for initiation or implementation of end of life care should be available, so that it does not hamper the routine treatment of other parts of the hospital, and it does not occupy critical areas. Okay, so probably if the patient has taken end of life care, we need not waste an ICU bed wherein the patient will be there just for bereavement, etc. Okay, so you will be reducing the family interaction also most of the times, right? So probably will not be able to give as much care as possible to this patient. So if they are moved to an end of life care facility, probably there they can be focused and round the clock services can be given very promptly. Education and training is very much necessary. Most of the doctors do not know about end of life care properly. So staffs like nurses, social workers, counselors, all of them have to be trained about what is end of life care, what to do. A hands-on training and mentorship should be given to them so that they do not have any hiccups while implementing end of life care. Documentation, when the patient and the relatives have understood that the treatment is futile and overall outcomes are very grim, then they have accepted end of life care. There is a structured format which is present, and based on the structured format, consents have to be taken. Additional support which is required is under special supports like your pastoral care department, okay, or any religious practices if the patient's family wants to do, etc. All of this has to be given to the family when they're looking at good end of life implementation. So the infrastructural requirement in summary are policy, space and staff, education and training, documentation, and special support. So, what are the principles, which is the ethical principles of end of life care? Autonomy, beneficence, non maleficence, and social justice, along with dignity. Okay. So, autonomy refers to patient's self determination, that is, the patient's own choice to do or not to do. Okay. So, the patient has the right to make informed decisions. He can give us advanced directives, and we should always respect whatever choice the patient makes. So this encompasses the ethical principle of autonomy. The next important ethical principle is beneficence, wherein we look at promoting the patient's best interest and minimizing the risk and maximizing the potential benefits. Okay, so we should always look at procedures which can do so. Okay, and majorly we should look at the quality of life in the overall outcome. So that part of the treatment is what falls under beneficence. Next is non-maleficence. Non-maleficence usually stands for first do no harm principle. Okay, usually we should avoid any unnecessary suffering, like unnecessary invasive procedures, etc. should be avoided when we all know that ultimately all of these things would be futile, like unnecessary putting the patient on ventilation, unnecessary prolonging ventilation, initiation of renal replacement therapy, etc. Okay, so we know that there is futility of care. Unnecessary prolonging the suffering is not supposed to be done. So that usually falls under non-manifestations. Social justice is an ethical principle which deals with fair distribution of care, equitable access to resources, non-discrimination, equitable treatment, and addresses the healthcare disparities. So this is something like a young patient usually takes precedence over an old ailing elder. Okay, so this is where we have to do justice, give a chance to a patient who has better chances of recovery than compared to a patient who might not make it. Okay, so this is a part of social justice. Autonomy, beneficence, non-maleficence, and social justice are all important, along with the major thing, that is dignity. The most important thing in dignity is it maintains the privacy of the patient, it gives emotional support, okay, and the patient will have some self-worth, okay, that should always be maintained. Okay? So the patient should not feel that we are overpowering his decision making or overpowering his autonomy. So all of this is necessary, and these are the ethical principles of end of life care. What is doctrine of double effect? The doctrine of double effect is an ethical principle that addresses situations where an action intended to do good may cause harm. So the core principle is initially an action that causes harm can be morally permissible if the nature of the act is good and morally neutral in itself. The agent's intention is good or aimed at a positive effect. If the good effect outweighs the bad effect in circumstances significant enough to warrant causing the harm. The good effect cannot be achieved without the bad effect. Okay, so to understand it better, okay, it looks like a lot of jargon. Let us take an example. Okay, so consider a terminally ill patient with severe pain. Okay, so when pain, what do we do? The good effect is relieving the pain, right? That is the morally right way to do it. So what do? We use opioids, probably we use morphine. So what is the potential harm in using morphine? It is respiratory depression because of the use of morphine. So there was an unintended respiratory depression which was caused because of morphine, which was primarily given to reduce the pain. So respiratory depression here caused because of morphine is under doctrine of double effect. And if at all any adverse event happens because of this, the physician will not be held liable. Okay. So here the important consideration are it should be able to distinguish between intended and merely foreseen effects. Okay. If you're foreseen some major issue, you should not go ahead and do it. Okay. So it should always weigh the risk and benefit and always try to minimize the adverse effect as much as possible. Okay. So this is about doctrine of double effect. Approach, how do we do that? Firstly, you need to have a informed consent. Okay. And then when you're having an informed consent, a clear decision making capacity should be ascertained. How do we do that? We need to check whether the patient is competent enough to give consent, whether the family is able to understand this. If the patient is competent, usually there will be no issue with cognition. If at all cognition and competence is lost, surrogate decision makers should be looked at. Who are the surrogate decision makers? Unless an advanced medical directive tells who it is, the next of kin is usually taken as surrogate decision maker. Legal guardianship, ethical consulting, all of them can be done when decision making becomes a difficulty. Okay. Withholding and withdrawing of life treatment is also a part of end of life care. It can be a patient's preference if it is mentioned in advanced medical directives. Whenever they are mentioning about withholding or withdrawing treatment, the repercussions or the risk of doing so should be explained to them, and then the implementation of any such treatment can be done. Overall, what we are looking at withholding and withdrawing of support is whether good quality of life can be maintained. Okay, so ethical principles, family consultations have to always be upheld when we are implementing withholding or withdrawing of life support. Pain management, nutrition, and advanced care planning are also part of good implementation of end of life care. So I told you earlier that is the best thing that we can do is pain management and nutrition. So this has to be continued until the patient passes away. Okay. So this is part of ethical principles as well. And whenever we do all of this, you should have a clear documentation as to what is being done. Okay. So the 6-step approach in end of life processes. What are they? Identify. So what do we identify? When to initiate and in whom to initiate. Okay. Along with that, assess for physical symptoms, non-physical issues like your psychological issues, depression, etc. Look for communication needs. Plan your site of care, whether it is hospital or home. If it is home, what are the anticipatory things that they need? Okay, equipment, drugs, etc. This has to be communicated, documented, and consent should be taken. Then you implement the end of life. Okay, and when you're implementing, you should have a dedicated, support system which is given to the family. Reassess them time and again, and once the patient passes away, give them bereavement support. Okay, and once the bereavement support is all done and your documentation, everything is done, you can reflect upon that particular case to look for any caveats which was present so that we can do a better job in the next patient. Okay, so this is usually the 6-step approach for end of life care processes. So that is identification, assessment, planning, providing end of life care, reassessment of the care given, and reflecting on the caveats which were given. Okay. So what is dying with dignity? It is a concept of good health, a good death. Okay. So usually there should not be prolonging of suffering. Good symptom management of pain should be present. Okay. And whatever social and spiritual requirements was put forth by the family, that has to be upheld. Okay. So usually we all know there is living with dignity. Death also should be done with dignity. So coming to points about withdrawal of life support and withholding of life support. What is withdrawal of life support? Withdrawal of life support is considered uh, when the patient's best interest is taken into consideration. Okay. It is to stop or to discontinue ongoing life support in a terminally ill patient in which we feel that treatment is no longer likely to benefit the patient. Okay. On the contrary, it can also cause prolonging of suffering. Okay. And it can also hamper the dignity of the patient. So withdrawal it's a considered decision when we feel that patient with terminal illness will no longer benefit from the treatment which is given to him, and it can in turn cause harm because of prolonged suffering and loss of dignity. Okay. The following conditions must apply. Usually, any patient who has been declared as brain death as per the Transplantation Act, medical prognostication considered based on patient's decision and advanced treatment, and a multidisciplinary consensus has been achieved. Patient or the surrogate has an informed consent or an advanced medical directive telling that they do not want to continue care beyond this. Okay. All of this should be in compliance with the proceedings of the Honorable Supreme Court. Okay. So usually it has to be a legal procedure. Okay. Whenever we are thinking of withdrawal of life support. So withholding of life support is in withdrawal. What is the issue? The patient is already on some life support. Okay. We are removing that life support. We are cessating that life support. And withholding, we are not at all initiating itself. Okay. So whenever we feel that patient is having respiratory distress or acute kidney injury causing a lot of issues, so we might counsel the family for escalation of care. So withholding is like non-escalation of care. Okay. Wherein a measure can be put down from the family or the patient after understanding the risk involved, especially in terminally ill patient in whom we know this particular intervention is only going to prolong the suffering and not overall improve the outcome. Okay. So the another important part of all of this is do not resuscitate. This is similar to withholding life support. This is also something that the patient has to give a advanced medical directive about. Okay. Especially when we feel that meaningful survival and good quality of life cannot be achieved by cardiopulmonary resuscitation. Okay. So coming to advanced medical directives. So I was talking about withholding, DNR, with withdrawal, all of this I told you about medical directives. So what is a medical directive? A medical directive is a written declaration made by a person with decision-making capacity documenting how they would like to be medically treated or not treated when they lose the capacity to do so. Okay. So, what are the legal framework which is available for implementation of advanced medical directive? Remember, an advanced medical directive is given by a patient with sane mind. Okay, so only that person can give it. Okay, and there is a procedure how they do it. So, what are the things that can be given in that? They can write as to how they want to be treated or how they do not want to be treated. Okay, so it's like telling what all treatment they want and what all treatment they want to hold. Okay, it looks kind of difficult from a medical perspective, but as a autonomy principle, we might have to uphold it. Okay, so coming to the advanced medical directives and living wills, the framework given by this Honorable Supreme Court in 2018 guidelines in Common Cause versus the Union of India, and there was a 2023 modification. Okay, in 2018, what the Supreme Court upheld was the right to life with dignity. Okay, so whenever that is hampered under the Article 21, it can encompass the patient to give advanced medical directives as to how he wants to pass away as well. Okay, so it is legally valid in India and it should follow prescribed formalities. Okay, so in 2023, what was the modification given? there were certain bureaucratic hurdles which were placed, okay? Like the family had to go to a judicial magistrate and then come back to implement this, and this would usually take some time, right? So we wouldn't have time. Time is of the essence when the patient is critical. So these bureaucratic hurdles were removed in January 2023's modification of advanced medical directives from Common Cause versus Union of India. Okay, so who can give an advanced medical directive? Any adult over the age of 18 years of sound mind and capability of understanding the consequences can give an advanced medical directive. It should be voluntary. It should be executed in a voluntary manner, and it should not be coerced. That is, no one should influence it. So, what are the contents of an advanced medical directive? The advanced medical directive should clearly specify the circumstances under which withholding or withdrawing life-sustaining treatment should be done. Okay, so when should we do this? That should be given. Consent for withdrawal of CPR, ventilator, dialysis, and tube feeding. A person should be nominated as a guardian or proxy. Okay, even a friend can be nominated to make healthcare decision when the decision making capacity of the person is lost. Okay, usually this can be revoked, okay, when the patient is felt non-competent. Okay, so competency of the patient will be challenged when he's giving an advanced medical directive. Formalities for execution based on the 2023 Supreme Court guidelines is the AMD should be written, dated, and signed by the person doing so. There is no prescribed format in how he must do it, but it should clearly indicate what are the patient's wishes. It should indicate a nomination of a proxy, and revocation rights also should be given there. Okay, so revocation rights meaning if at all the patient wants to change his decision, when should it be done? That should also be written. And when will it be considered valid? Once the patient gives an AMD, that is an advanced medical directive, okay, nominates his proxy and makes sure what all has to be done. It has to be witnessed and attested by two people. Okay, so this was the bureaucratic hurdle which was removed. Okay, so attestation can be done by any two witnesses, and it has to be countersigned either by a notary or a gazetted officer. Okay, so if this is done in the presence of a notary or a gazetted officer, then an AMD is considered legally valid. Okay, so how do we implement this? Okay, so initially the patient gives an AMD. Firstly, it will be reviewed by the primary medical board. Okay, similar to what we see in end of life decisions. Okay, so primary medical board is again the same. Okay, the doctors, like I'll be discussing in the further slides. So once it is reviewed by the primary medical board and the secondary medical board, if both of them feel that it is legally valid, there is no issues to stop the patient from implementing end of life decisions, then this AMD can be held up and consent implementation can be done. The whole process has to be documented. Okay, all the medical records whenever the patient has an AMD has to be thoroughly evaluated and then recorded. So it follows a similar principle as we do in end of life care decision. It has to go through the primary medical board, secondary medical board, and finally implemented. So constitution of primary medical board and secondary medical board. So primary medical board is constituted by the hospital or an institution in which there is a primary physician and at least two subject experts who have more than or equal to 5 years experience in that particular subject. Okay, so members of the primary medical board usually should be a multidisciplinary team. Usually they consist of neurologists, intensivists. Okay, so they should broadly be involved with understanding patients with multi-system disorders. Secondary medical board, on the other hand, is constituted by the hospital institution with one registered medical practitioner nominated by the CMO. Okay, so usually along with these people, the nomination of RMP will be done from the state government. Okay, this is the provision of the state, that is to nominate a regional medical practitioner as a CMO. Along with this person, two other subject experts can be present, similar to what we see in primary medical board, who should have an experience of more than or equal to 5 years. So a secondary medical board, a member from the primary medical board cannot be a part of secondary medical board. One doctor should be nominated. He may be from the same hospital or he may be from outside, but this nomination comes from the state. Okay, so along with this, two other doctors should be present. Okay, So there is no bar on all doctors in the boards that can be from the same hospital. Okay, primarily if they're from the same hospital, there is no issue. Okay, if at all it is there, good. If it is not, one person will always be there from outside. Okay. So all of this will be under the purview of the clinical ethics committee of the hospital. Okay, so all of this would be done under the purview of ethics committee. So whenever there is a case, it has to be addressed to the hospital ethical committee. The ethical committee is the one who would have the list of primary medical board and the secondary medical board, and then they will look into the case and implement it. Okay, so how do we implement it? Whenever there is decision for end of life care, there will be a consensus which would be formed by the primary medical board, and once that is reached, it should be sent to the secondary medical board. So once both primary and medical board and secondary medical board have agreed on to it, then we can go ahead and implement end of life decisions. Whenever there is no consensus or no approval either by the primary medical board or the secondary medical board, it can always be subjected to a consensus call. Okay, so you can have a meeting with all the parties involved and try to reach an understanding. If at all you're not able to solve this, then it can be appealed to the court, that is your judicial magistrate court of first class or even the high court. Okay, so always there is step one wherein all the parties who are involved, the PMB, that is a primary medical board, and the secondary medical board, or the family, okay, if any of them have an issue with implementation, they can sit, discuss. Only when all the three are in consensus, only then we can go ahead and implement. If any one of them are not in consensus, we cannot implement end of life approach. Okay, so this is about implementation of end of life practices. Thank you. So the next topic is breaking bad news. Okay. So these are parts of miscellaneous topics that I wanted to continue. Okay. So breaking bad news and conflict in ICU. Coming to the introduction, communication is one of the most important and crucial aspects of patient care because patients are often critically ill, and because of which families are usually anxious, and majorly when we ask them to do take decisions, it will be under stress. So this is a very tight scenario, correct? So communication in such scenarios become very important. So what is the importance of communication in ICU? It should ensure clarity in patient care goals among healthcare providers, patients when possible, and to the family. All three of the groups which are involved should have an idea of what is happening. Next, we should always build the trust because the two parties are new. Okay, we should have trust on the family, and the family should have trust on the treating physician, wherein we can reduce anxiety and have ease of care for the patient. Okay, that is the primary focus. Most of the times, shared decision making is what is necessary, especially when we are thinking about end of life decision. If we do all of this, that is, if we ensure clarity of thought, build trust, reduce anxiety, involve family in shared decision making, it usually reduces conflicts and misunderstanding, and better healthcare delivery can be given. So what are the key principles? So now we have understood that. So the key principles are clarity of thought. Whenever you're talking to the family, use simple language, avoid jargon-free words. It should be an empathetic way, okay? Acknowledge the emotions of the opposite party and show compassion. It should be transparent, share good and bad updates honestly. All team members should provide uniform information. There should not be, disparity between communication. So consistent information should be there. You are telling one thing, your surgeon tells another thing. Okay, that should not happen. So usually best way to do it is together. If not possible, whenever it is happening, it should be coherent. Always have active listening. Listen to what the concerns of the family are, however trivial they are. Address them so that it does not build into a mountain of pressure later on. Okay. So what are the modes of communication? Again, when we're talking of modes of communication, firstly, we need to know whom are we communicating with, whether it is a patient, family, within the healthcare team. All of this is a part of communication. And how do we do this? It can be verbal, non-verbal, or with some charts, etc. Right? So what are the types of communication in ICU? Firstly, we have verbal. That can be direct conversation, formal discussion, telephonic conversation, etc. Non-verbal, usually it looks at body language, facial expressions, eye contact, okay, touch, proxemics, posturing, and gestures. Written communication majorly looks at medical notes, charts, consent forms, summaries, medication orders, care plans, etc. Communication tools in the era of AI, we are looking at electronic health records, telemedicine, video consultations, etc. Interprofessional communications, usually when we have it as major in handover protocols like the S bar or IS bar. Okay, so that we have a structured format wherein we do not miss the key aspects of handing over, which is very much important to have a continued process of care. Okay, so this is another type of communication. And lastly, and most importantly, family communication, especially when it comes when we're giving bad news. Okay, talking about prognosis, treatment options, informed consent, end of life care. Okay, all of this we need to look at that. Okay, so what are the principles of communication? We need to look at how do we prepare, how do we assess, how do we deliver, how do we validate, and how to follow up. Okay, so in preparation, you have to do communication in a private, quiet, closed environment. It should have minimal interruptions. Better to have a team. Okay, usually a senior staff, nurse, etc. can also accompany you. Okay, along with appropriate seating, comfortable seating, and then introduce yourself. That is very important before you start communication. Okay, so you don't know who the opposite person is, so you start by that, break the ice. Okay, so introduce yourself first, make sure that the opposite patient person is also comfortable, and then start your communication. Next comes assessment. In assessment, what do we first do? Firstly, we acknowledge the person's emotional issues if there are any. After that, you need to identify who the proxy is. After identification, we need to understand what is the understanding capability of the person. Okay, so you need to make sure that the opposite person understands what the plan of care for that particular patient is. Okay, so for that you need to understand the level of understanding of the relative or the patient. After having understood all of this, we need to deliver it. What do we deliver? A clear, compassionate communication about the current health status. What is the prognosis? If at all there is hope, provided. Otherwise, please lay down the facts based on evidence. Okay, so this is what we look in effective communication. After having said that, always validate. Okay, listen to the concerns of the person. Okay, give them emotional support. Check for comprehension. After you have given your delivery, after you have told the prognosis plan of care, ask them, do you want to ask anything else? Are you clear about it? Is there anything else you want to know? Okay, so this is about validation. Finally, you will have follow-up. Follow-up is documentation of the above said things, wherein you document a plan of care, you will document prognosis which has been explained, you will document what are the risks which have been explained. Okay, all of this is something that we do in communication and follow-up. So whenever we have communication which is looked into, it can be in two settings, right? One is an emergency situation, one is a planned discussion. In emergent discussion, always time is of the essence. We don't have much time. So you'll come, introduce yourself, give a clear, concise message, and tell them that you will come back and talk to them in detail later on. The only thing you will want to check at that time is comprehension of whatever the message you wanted to give. Say, for example, you have a patient with cardiac arrest. We'll just go identify the person who's there outside, tell them that you have an emergency news that you have to break in. You will introduce yourself, tell them what the news is, tell them that you're doing everything possible to revive the patient, and you will come back and give a brief detail after having said, done what is necessary. So that is what we do in an emergent situation. What do we do in a planned discussion? We have all the things that I mentioned earlier, wherein you prepare, okay, and you make sure you assess the person, deliver, you validate, and then follow up. Okay, so that is what we do in a planned discussion. In an emergent discussion, we might usually skip few of the non-essential things. Okay, so whenever we're talking about the things that I mentioned earlier, always introduce your team, explore the current understanding, identify what is the goal that you want to reach. After that, give all of this, validate and conclude and document. Okay, these are the effective steps of communication. Okay. So coming to breaking bad news, okay, what do we do? Usually the goals of communication during end of life care becomes a really taxing one. Okay. So establishing consensus about the disease processes among the caregivers is very important. So you should not tell that there is hope and someone else comes and tells no, there is futility. Okay. So that should not happen. There should not be disparity. There should be clarity. Okay. So that has to be established. Once you have done that, then go out and then give bad news, whichever is there. Okay. So it should be accurate, it should be appropriate. Okay. Nothing less or nothing more. Okay. Along with this, look at what is the patient's family's concerns or patient's concerns, and you have to elicit them and resolve the concerns at the same time and do not push it over. Okay. Preliminary approach whenever you're giving breaking bad news. uh, how do we do it? You can remember the mnemonic value stands for value the statements by the family members, acknowledge the family members emotions, listen to the family members, understand what the patient or the family member wants, okay, and what decision making is awaited based on their understanding, and then finally conclude by eliciting questions, okay, so that you can, one, understand that their comprehension is good, two, you have given them an opportunity to close the communication. Okay, so this is one useful mnemonic value. Okay, statements, acknowledgement, listening, understanding, and eliciting. Okay, coming to non-verbal communication, the tool we all know is solar. Okay, so solar stands for face the patient or the family squarely at eye level, indicate that you are interested in involvement. Okay, don't look down, always maintain eye contact. Adopt an open body posture, don't crouch and don't look very shabby. Okay, you should be looking like you are interested to know what the opposite person wants to say. Lean forward to the patient or the family and listen to them. Always use eye contact to show that you're paying careful attention. Okay, and maintain a relaxed posture. Don't look like you're in a hurry to go somewhere. Okay, so solar stands for squarely at eye level, open body posture, lean towards the patient. Okay, and maintaining of eye contact and relaxed body posture. This is solar. Family centric approach, again, the useful mnemonic is spikes. Okay, I told you earlier, right? When you're communicating, I use those. You can remember it in setting, perception, invitation, knowledge, emotion, and summary or strategy. Okay, it's similar to what we did earlier. Okay, setting is the quiet environment, comfortable seating, introduction of the team. Okay, timing appropriateness. You have to ask the family also so that all of them are not having any issues. Perception, again, you should know what is the comprehensive capability of the opposite party. Invitation is to ask them, would you like to know about anything? Would you like to discuss about the test results, etc.? Okay, and knowledge is after you've given all the details to them, understand, ask them to tell you what else they want to know and what have they understood. So finally, if at all it's bad news, obviously they will break down. So you have to acknowledge the emotion, okay, and be empathetic towards them, okay, and in the end summarize and document whatever has undergone. Okay, that is most important, though that is spikes protocol. Okay, coming to the last part of the miscellaneous topic, that is conflict in ICU. Okay, conflict is a complex behavior where one party perceives that it is the interest uh, conflict is a complex behavior where one party perceives that its interests are being opposed or negatively affected by another party. Okay, usually it is two meme types. Okay, so dysfunctional conflict usually hinders individual or organizational performance. So one feels superior over the other, etc. So this is very common in the medical background. Okay, so these issues are things that we face on a daily basis. So how do we deal with conflicts? Conflicts can be of different types. What are they? Firstly, you need to know there are professional conflicts, that is between the healthcare team members, disagreements on treatment, hierarchical tensions, and communication breakdowns. Second type of conflict is between the patient and the family. Sometimes patient wants something, the family wants something else. So usually there will be a difficulty in coming to consensus when this is present, okay, especially in end of life care choices, etc. Finally, ethical conflicts are one things which are really difficult to handle. especially when it comes to treatment futility, autonomy of the patients, resource limitations, and cultural differences. Okay, so these are the conflicts which is by and large present. Okay, so there are various factors that can cause conflicts. Okay, so this is what I have categorized and put it in the previous slide. So you can remember it as professional conflicts, patient family conflicts, family physician conflicts, and ethical conflicts. Okay. What is conflict resolution? Okay, we'll look at a comprehensive approach. Majorly two things that have to be looked into. Okay, first major problem with conflict is poor communication. Okay, we have to actively listen to the opposite party, have an empathetic approach. We should clearly communicate, maintain neutral language and respect throughout the conversation. So part B of comprehensive approach is emotional management. Recognize the emotions, especially when it is between physician and the family or a patient. Okay, so we will be thinking only towards medical management. The family will be thinking of the other aspects as well. So we have to uphold that and respect that. Okay, so control personal reactions, validate the feelings, and remain professional throughout. Okay, so there is no best way forward in conflict resolution, but one good thing is interest based negotiation or principled negotiation. Okay, so what is principled negotiation or interest based negotiation? It is a collaborative response to conflict. Okay, so here it is like a win-win situation wherein we come to a middle ground. Okay, usually it cannot be so, but at least both the parties will go back thinking that they have won. Okay, this can be achieved, okay, based on proper understanding. So how can we do this and what are the advantages and disadvantages? So interest-based negotiation is advantageous by breaking the typical conflict cycle. Okay, so arguments can be broken down. We will be giving them time to have a structured thinking and process. Interests of both the parties will be taken into consideration. Options will be analyzed and then implemented. Okay, it helps us separate the important from the unimportant and helps us negotiate constructively. The only disadvantage is probably there's still going to be some amount of suspicion and mistrust at the end of it. Okay, so how do we do this? First, we need to explore shared interests. So all of us want the good for the patient itself, right? So we need to reach the middle ground. Okay, so each party analyzes what is the middle ground. Okay, and then we have to come to an understanding what is the best way forward. Secondly, we have to look at each other as an ally and not an enemy. We have to look at risk versus benefit, agreement versus disagreements, and then come to a middle ground there also. Okay, so usually there should not be any conflict. Okay, so enlightened interest should be achieved after brainstorming. Okay, so it should be that this patient, or the person that we are trying to treat should have optimal outcomes on middle grounds. Okay, so that both the parties do not have any issues when implementation. Okay, this thing comes into picture when we are talking about end of life care mostly. Okay, so once we are able to do all the brainstorming, we have chalked out a plan of action. We have come to an understanding that both the interests are aligned, and then there is no negotiation which is hampering each other. Okay, so mutual consensus can be agreed upon. So after this, we come to implementation of whatever decision that has been done. So what are the take-home points in breaking bad news in the ICU? Always prepare well, gather the facts, be consistent, assess the understanding of the opposite party, be clear and honest. Don't give any false hopes when there are none. Acknowledge the emotions, offer support to the family. Use frameworks and mnemonics like spikes, solar value, etc. Okay, so always recognize futility of care. If at all there is a conflict which comes in, sit, discuss what is the pros and cons of each thing, and then find the middle ground and implement them. Always build trust because you're dealing with people on a daily basis who are new to you. Okay, so the only way that we can go about and get best treatment is by building trust. Okay, concessions can be done wisely when we feel that patient-centric values are not going to be compromised. Okay, and whatever we do in all of this in end-of-life care, communication, etc., it should be documented always. Okay, and this is because it always one We have a backup for any legal issues, and it always maintains transparency between both the parties. Okay, so you can look at the same end of life plan which I've mentioned earlier as well, to look in about how to deal with breaking bad news. Okay, thank you. If there are any questions, I'll be happy to answer in the WhatsApp group. Okay, since this is a recorded session. I'm sorry because I had some technical glitches which I'm still trying to solve. Okay, thank you.